I'm Noel Latif, President of the Foreign Policy Association. I'm very pleased to welcome to FPA Live our FPA Fellow, Steve Brozak, who will deliver the Dame Jillian Sackler Distinguished Lecture on Global Health Issues. This lecture series was inaugurated 10 years ago by none other than Dr. Anthony Fauci. We welcome questions from our viewing audience, and you can use the Q&A button on your screen to ask those questions. Our speaker today is the managing partner and president of WBB Securities, an investment bank and self-side research firm that focuses on healthcare, biotechnology, pharmaceutical, and medical device research. Steve Brozak has specific expertise and interest in human stem cell therapies, biothreat countermeasures, and viruses such as highly pathogenic influenza, Marsburg, and Ebola. Steve has published widely and has been frequently interviewed by mainstream media. He is a retired lieutenant colonel in the US Marine Corps, having served in Europe, the Middle East, Asia, and the Caribbean. He is a graduate of Columbia College and Columbia Business School, and Steve has received a Doctor of Medical Humanities from Drew University. Steve, the floor is yours.
Well, thank you. Thank you, Dame Sackler, for this opportunity to speak. Thank you, Noel. And thank you to the Foreign Policy Association for this window and allowing me to answer some questions and make some statements around SARS-CoV-2, the coronavirus. With that, I will jump into the presentation. This slide has changed over the last week, and that a statement of concern has taken it over, and that is one of irrational exuberance, which I'm sure a number of listeners and viewers can look at and understand applied to the 1996 stock market bubble concerning internet stocks. But the euphoria is something that really has to be challenged, because right now is probably one of the most critical times we're facing in dealing with this pandemic. And starting with that, I want to directly address SARS-CoV-2. Not looking to make anyone a virologist, and candidly myself not being one either, but having spent a great deal of time with highly pathogenic problematic diseases to include H5N1, H1N1, Ebola, Marburg, and the rest. This virus is not the flu. We have a picture here showing the overall spike patterns that give it the corona type effect, which is why they call it a coronavirus. But versus influenza, which unfortunately a number of people presented this as being just a bad case of flu, it is not. It is completely different in many, many ways that are critically important. What I hope to do is explain to you what are the similarities in terms of course, it is a virus, but also what are the issues around what type of virus this really is, and the fact that we have seen this type of virus before. The next slide I go to is one that used to be more important, but I still keep it in. The differences between bacterium and viruses. A lot of people, up until very recently, were always under the impression that you could provide antibiotics to help with viruses. And candidly, it is not just problematic, it is actually very harmful. And at the end of the day, what we see with this virus is that it does one and only one thing. It lives to replicate. And anything that gets in its way, it tries to figure a way around it. The other part of this virus is that we are right now as good a host. In other words, we are the perfect partner for this virus, and it looks to do nothing but go from person to person as much as possible. Now, there are obviously other cases of humans to other animals, but right now we are still the best receptacle for it. And that is something that we really have to consider in everything that takes place. The other part is, how do we start to look at data points around this virus? What are the significant issues that we should be focused on? I'm sure everyone is familiar with Johns Hopkins and the wonderful job they've done in presenting data. This is about a week old. However, there are issues around this that I really do want to address. The first one is, even though the red glaring signs of infection are there, we see signs that are black and that give us a pause as to whether or not people are infected there or whether we have issues around that. We don't. The issue and the problem is that we don't understand, we don't have a good grasp of distribution of disease. And it's something that we really have to carefully consider in being able to fight this disease. In the areas of Africa, there simply isn't reporting. In areas of Asia, there is reporting, but it is ad hoc. And even in the United States, as we'll see in the next slide, we have issues around reporting. I don't know if everyone can make this out, but for instance, with the top right-hand slide, we see something that unfortunately should be self-evident in the form of death, but you see gaps in Florida reporting on deaths, and you see spikes in areas where there's a question mark. When we don't even have total transparency in this type of, candidly, self-evident reporting, we have issues. And the facts are that we need the data today more than ever before. And one of the things that is striking is The Atlantic, a magazine, has, from the very beginning of COVID, its journalists and its volunteers have gone out there and provided us with real-time data as to how information on deaths, infections have taken place around the world. And they just a week ago announced that they were going to suspend this activity. I would challenge anyone that right now is the time that we need to understand COVID more than ever before, and that we need the best data that we can possibly get to deal with it into the future. Now, the past is a good indicator of what has happened, or what will happen, of course, of what has happened in the past events. But what we're now looking at is, how does this affect what we're looking at today and into the future? So, when I say that this is not the first time we have been struck by a coronavirus, there is a documented situation that took place not in 1918, but in 1889, a pandemic. And at first, there was much documentation suggesting that it might have been an influenza pandemic. But two research groups, one out of Belgium and the other one out of the Nordic countries, picked up anomalies that can only be explained by a coronavirus pandemic. Those were, in the case of Belgium, and they were able to find patterns of coronavirus infection doing what they call seroarchaeology that went back from drawing blood samples in the 1960s of patients that had been infected with a common coronavirus antibody. And at the end of that, they were able to go back and figure out that by replication differences, every time the virus would replicate in another person, you would see slight changes. Drawing back using that data, they were able to go back to 1889, which obviously was the documented start of this Russian or Asiatic pandemic. They also started to document other issues around mortality, but the convincing part obviously was the seroarchaeology, which was then confirmed in the Nordic countries by a couple of different groups that went out there and started to document the case studies, specifically everything that they had printed, whether it be hospital records, birth, death records, and even newspapers had been digitalized to the point where they were able to pick up the common phenomenon that we see today. The central nervous system issues that we talk about, and I'll talk about a little bit later, but right now it's important to remember the loss of smell, the loss of taste. These are issues that affect the central nervous system. They were also well documented there, and they also provided a window into understanding how prevalent it was, and also the mortality rates and actual waves that took place. So in thinking about this into the future, we have to think about, well, is this a short-term phenomenon, which obviously initially people wrote extensively about, and how close this was to flu, when it's simply not the case. Another example, what must we relearn? We are starting to see documentation of mothers passing vaccination antibodies into their infants that are born, that are able, you can actually see the titer levels of these antibodies. One issue that was documented in 2013 was a statistical study that looked at mortality for the 1918 pandemic, that, as you can see, that spike there was in 28-year-olds. This paralleled an unfortunate death rate that was attributable to prior exposure to another virus in utero, and specifically in this case, the coronavirus of 1898. And at 1889. And at that point, the researchers started to postulate that the infants that became adults, their bodies were triggered to look at a different type of immune response. These are issues that we're only starting to recognize right now. And this is where the critical understanding of data, additional data, more data is so critically important. Again, this is real time. Yesterday, Nature published this particular piece that I'm drawing a document from, and it's specific to the description of what they call the long hauler syndrome, which frankly is still being discussed in terms of what are the particulars around it. Why is it caused? Why do some people that are asymptomatic express it much, much later after really no reason to? And how do you deal with it? These are issues that we really do need to understand. And candidly, until we do, we're always going to be playing catch up. Now, before anyone starts, I want to put this disclaimer in. Vaccines have saved more lives than all other therapeutics combined. There is no equivocation here. Going back to this diagram here in 1796 showing crude and rudimentary vaccination plans dealing with cowpox, it can easily be said that we cannot denigrate or we cannot distrust anything dealing with vaccines. However, vaccines are not the perfect answer. As a matter of fact, we have problems here that I do need to discuss and that are critical to understand. In something as simple as distribution, the vials around what we deal with the different vaccines need to be of a special type where we're just simply in shortage of them. People know about the constraints around temperature and everything around that, but we're now all of a sudden starting to see issues in distribution from, we literally had to buy an additional 5 million needles from the Chinese just to get our vaccination program underway. These are critical issues that we really do need to understand and deal with in a realistic fashion. And again, in dealing with just the AstraZeneca data that was just presented and the NIH or the NIAID's comments around data around that, we need to understand that better. And we need to look at what are some of the solutions that we may want to think about. One of the other weaknesses, it doesn't unfortunately take much reading to find out that there's a big question mark around trust, or I should say distrust of vaccinations. A vaccine isn't just a therapeutic, it's a social contract. And in order for it to work effectively, you've got to have a significant percentage of the population inoculated, not just here, but globally. Whenever you have shortcomings, whether they be due to simple manufacturing constraints, distribution constraints, or even public acceptance hesitancy, it puts the strategy at risk. And right now, we are at a crucial point as to whether or not we can effectively execute on this strategy. Additionally, and specifically with the coronavirus, as of last week, according to this diagram, we are looking at variants now express themselves more in New York City by 51% than the original wild type to which the vaccine was designed. This means that at best, you're not going to see complete coverage given variants and variant exposure, which also leads us to another question as to what are some of the issues that we face. In the past, variants have typically happened because you've had significant swaths of unvaccinated populations, and you've had treatment-naive patients expressing variants and building them up. In this case now, with a wide number of people that have immune issues, either impartial immune systems or complete absence of immune systems, They are literally people around that can act as petri dishes in developing multiple variants and doing something that would have normally taken literally perhaps even years down to weeks and days. And this is something that was not contemplated in the beginning. So at the end of the day, we now have to think about how do we go out there and deal with the exposure to these new variants, to these new issues that we're talking about into the future. And this is where I bring the idea of therapeutics. One of the particulars here is the fear. Obviously, people fear getting the disease, but more than that, they fear having significant negative outcomes, to include death. And this is where we have to understand why this is not flu. This is a chart, and I'll pull no punches here. We focused on a strategy of immune response, how to go out there and shut down the immune response, which in this particular case is called the lectin pathway. This is the immune response that you're born with. And the idea was to be able to find therapeutics that could effectively stop an inflammation that took place. And why is this important? Well, the damage is not caused in the conventional sense that most people that are expecting influenza. The damage is caused by a far more pervasive approach. And this next slide demonstrates exactly what I'm talking about. Inside you have a picture on the top screen, you have a picture of a vessel. And within that vessel, you have the blood that circulates through the vessel. Looking at it, on the inner wall of the vessel, you have what they call the smooth cells or endothelial cells. These are cells that provide for the easy passage of blood. What happens with the triggering of this attack via COVID is called a microvascular attack, and it causes a coagulopathy, or in simplified terms, a clot. These clots can develop throughout the body. They can develop in the lungs. They can develop in the heart. They can even develop in the extremities. When you've heard of people that have had issues around their arms and legs and unfortunate amputations. The loss of smell and taste are issues where you see clotting in the central nervous system. Usually it resolves fairly quickly, but unfortunately, in some cases, the damage is permanent. And again, this is where it differs completely from influenza, where it's not just limited to the lungs, and it's not just something where if you can get by, you won't have damage, or eventually the damage will be reparable. In some cases, unfortunately, we're just still starting to get around it. Now, what does this mean? Well, it means that in thinking about this and preparing for what we need to do, the idea was we would need to figure out about how to do detection and then contain and respond using things like therapeutics if we weren't going to be effective in a vaccination program. But what we're now seeing in places like Brittany we're seeing detection evading coronavirus, where they cannot be picked up by conventional PCR. And this is something where data and the understanding of real-time information becomes critically important, obviously for a vaccine strategy, but critically for a detection and a therapeutic strategy as well. What are some of the other issues we need to contend with? We're tired. It's a simple fact. You're seeing a picture of the Sturgis motorcycle rally, but these types of events add nothing but fuel to the fire of spread. And we now need to consider that, yes, we have a vaccine policy that's in place, and it is proceeding. However, it's got to be considered that this is the most difficult time because we have to still contain the virus using conventional masking and social distancing. Another picture of an event just right here in New York City that causes us more concern as to what can happen next. And I'm sure everyone wants to say that they're off to Disneyland that's just reopened. But again, these are venues that lend themselves uniquely to the spread. And at the end of the day, we also have to consider that whatever happens in one part of the United States is obviously going to affect another. And as we can see with the states in gray here, Florida, Texas, and even Mississippi, These are now states that really have no restrictions. They have no issues. And with spring break taking place, this is obviously a super spreader event in the happening. And unfortunately, you can calculate the number of days until you start to see mortality rates increasing in other states external of Florida. What does this come down to? Well, one of the solutions, one of the things that we need to consider are how do we go out there and effectively make sure that there's a universal and a different way of approaching this. Last week, the Rockefeller Foundation here in New York City made an announcement concerning a pandemic prevention institute. The idea would be that we now have to go over different national agendas and obviously geographic restrictions and think about how we're going to go out there and how we're going to position the world to be able to deal with the coronavirus and the issues it presents. And in the Nature piece that was on just on Friday, it describes Dr. Rick Bright, who was the original head of BARDA, and the approach that he took to dealing with the pandemic and going out there and understanding that data and science were the critical parts, and that we needed a global perspective and global partnering to be able to deal with it. Which brings me back to where we started, which was the FPA. The FPA's legacy of having started after World War I, quite literally after the last pandemic, is something we should think about as far as how do we go out there and combine? How do we go out there and form partnerships? How do we go out there and effectively mine for data and questions specific in terms of what the coronavirus does, and also general in terms of how do we go out there and ensure that we have enough manufacturing, resourcing, and the proverbial last mile to go out there with therapeutics and vaccines into the future. And with that, I'm happy to answer any questions.
Steve, the New York Times has editorialized that the success of the Biden administration's $1.9 billion stimulus package may ultimately rest on the ability to boost the number of coronavirus screening tests, which have been on the decline in recent months. And Mayor de Blasio said recently that without adequate coronavirus screening tests, New York City had been like a plane flying without radar when the pandemic began. How can these screening tests be made more widely available?
Thank you for the question. The tests can be in a couple of different ways. Obviously, the technology is changing and demands change, but point of care tests, in other words, it's a staggered strategy. So you're not just dealing with tests in the hospital, but you're dealing with tests at home, which will soon enough be available at home, in pharmacies, in different places, so that you've got a defense in identifying the pathogens. Also, the difference in pathogens. For instance, as bad as the results were in Brittany, where they were seeing PCR eluding variants, the idea is now we are aware that we have to start changing things as far as that goes. And let me not limit it to testing for the coronavirus, because one of the single most problematic issues around coronavirus infection for those patients that do succumb is sepsis. We need to start also thinking about how to go out there and identify pathogens that actually do exacerbate the issue once that problem, that inflammatory episode takes place. So it's not just in one test, it's in a staggered series of testing from hospital to the community, multiple testing and continuous, and the ability to get that data point out. As a matter of fact, right now, NCATS, which is a part of NIAID, just established that they just tracked their millionth patient as of yesterday. That kind of data is critical in our being able to deal with the coronavirus and eventually defeat it.
Steve, how do you rate the Biden administration's vaccine rollout thus far?
I think that the Biden administration has gone out there and they have made a clear message of the number of vaccines that they want to implement. I think that they should, at the same time, go out there and not say that this is enough. This is just a first step, so that there can be no illusions that there will be the need for continuous monitoring, that there will be the need for the development of therapeutics, that this is not a just around the corner approach to back to the normal days in 2019. This has got to be only the first step, and not to build expectations to that point that I made about irrational exuberance.
When you spoke to my class a week ago at Baruch, you quoted someone from CDC as having said that given a choice between wearing a mask or taking the vaccine, if that were the two choices, he would go for the mask. When will we be able to put away face masks, or are they likely to be recommended protective gear indefinitely?
I would say to you that after he made that statement, he also said, and it was then passed on, it's not just wearing a mask, it's not just getting an inoculation, it's also getting an inoculation and wearing a mask. I would say if the past is any indicator of the future, we are looking at the possibility of having to more than likely wear masks for multiple years, and also changing behavior for multiple years. I think that that's something we really need to consider. I do believe there are questions out there. Let's see here. There is a question from Leonard Levy. I'm sorry. Are Western vaccine producers making enough vaccines to inoculate the world's population? Do you think that the US and the UK governments should remove all patent protections for vaccines? On the patent side, candidly, the patent systems don't really interrupt the system, because the level of sophistication required for manufacturing is so great that the know-how isn't as important as the ability to actually do it. And do I believe that the producers are making enough? Well, the irony is that they will have made enough vaccine. However, it will be for the wild type. And we have to think about making vaccines right now for the identified variants. Let's see. A follow-up question: what is the view with regard to probable source of COVID-19? Did it likely emerge from a wet market or from a lab? I can't be specific, but I can say that I think greater transparency is probably required from the Chinese government in terms of one simple thing, going out there and examining blood that had been collected from blood donations during the same time that the pandemic started would give us a better indication of how widely it was distributed. And that's something that I think should be done relatively quickly. From Darcy Jade, do you think the WHO should be divided into pandemic response and general health subdivisions? Right now, I believe that this is a function of first aid. Stop the bleeding, start the breathing. I think that right now, the WHO its sole mission is to be able to coordinate the pandemic response and to gain its strength from that and credibility. After that's done, we probably could look at other approaches. From another questioner, will boosters be necessary to protect against the variants? They will absolutely be necessary. The question is a function of how many boosters will we need, and what do we need to do as far as that goes into the future. Let's see. One more question, more political. Does China have a moral responsibility to finance and facilitate vaccine manufacturing and distribution worldwide? That's a topic that candidly I do not believe is it within the realm of what we're looking at here in understanding that right now we need data and how to go for data, how to respond with data?
Steve, I'm going to jump in now. I had occasion to observe in the 2000 issue of Foreign Policy Forum on deconstructing globalization that, quote, FPA's members take a keen interest in global health, and polls consistently show that it is an issue that arouses interest in the public at large. A grassroots approach to this issue could reap important dividends, not the least of which would be reprioritizing of health issues in the formulation of US foreign policy, end of quote. Do you think it would be prudent to have representatives from the CDC seconded to US embassies in some regions of the world?
I think that right now, it is a good first step, but I can tell you one thing that I've seen: the level of distrust unfortunately, within different U.S. government organizations is so significant that I'm not certain as to how their reception would be taken. I think that in looking at going out there and augmenting the CDC with other global organizations, I think that that is probably something we should start considering right now. And I think that as far as what the CDC will need to do, obviously for the first time, I believe that they have enough funding right now to go out there and start to address some issues. But right now, I would probably say that that would be something we want to consider later on, and possibly in conjunction with the EU and other organizations that are set up, for instance, in the UK and in Japan.
I'd like to go back to the World Health Organization. The current pandemic really underscores the importance of global surveillance systems that can alert the international community to outbreaks of infectious diseases. In the current issue of Great Decisions, we have an excellent essay on the role of the World Health Organization. And I'd like to put to you the discussion question at the end of the essay. Should the main function of the World Health Organization be to prevent any future global outbreaks like COVID-19? You said earlier that you would focus it on the current one, but should it be positioned in a preventive mode?
I think that it's obviously, again, the ultimate goal. I think right now, and there was a question here concerning a third wave of COVID in the EU. I think that we still need to consider how we get out of this pandemic and what we need to build to get out of this pandemic. That will more than likely be the bridge into how we deal with future pandemics. And in answering the question on the recent shutdowns and the recent wave of new infections in Europe, it's simply tied to an opening up, a premature opening up of their societies, where an abandonment of mask wearing, an abandonment of social distancing, an abandonment of these simple steps really easily and very quickly leads to additional infections. And it is not up for debate. These are issues that we can deal with it right now, and candidly, it is the next step that will get us out of the return of infections.
Can you comment on the challenges facing the school systems around the country? Do you think that opening the schools at this point is the appropriate policy?
I think that it is something that is far more challenging than anyone would have thought. And that is a critical question, because right now we are seeing significant damage taking place to young men and women without the socialization that is needed. And there was a movie way back in the 1950s titled "The Best Years of Our Lives" that talked about how significant years were taken away from people, from young men and women that were drawn into World War II. I think that it's something that we really have to understand and consider, that in addition to the damage that is caused by COVID, that the damage that is caused by the lack of the socialization that we experience in school and other places is something that we also have to address, and is also something that is critical. And candidly, it can't just be well, a vaccine will take care of that, because it won't. These are other issues that we have to think about, and other social structures that we need to develop. I do have a question here from Sungmei Cheng. Sorry. When is a realistic time that the emerging market and developing countries may expect to have the majority of their populations vaccinated? Is the main obstacle the cost? Will pharma companies reduce prices to meet the ability to pay for these countries? The real problem is manufacturing bandwidth. It's not that we don't have facilities that can make drugs and vaccines. It's that we don't have sufficient facilities to make them all at once. And at the end of the day, even if you were to go out there and say, here's an unlimited supply of money, we don't have enough bioreactors, fermenters, to go out there and make the products that are critically needed right away. And in addition to that, there's a lot of this that involves more art than science. So at the end of the day, you're looking at how do you go out there and ensure that the quality of these vaccines is uniform. The last part is, just because you have a vaccine or therapeutic doesn't mean that you literally have the arm that can be rolled up and injected into. You now have a situation where you have to think about, how do you get it to that proverbial last mile? And that's something where pricing isn't as important as just quite literally infrastructure that we just don't have at any cost right now.
Let me jump in there, because one of the things I've been thinking about is at what point do you inoculate various age groups in society? And in that same essay I quoted earlier in Foreign Policy Forum, I wrote, early in 2000 in Davos, Switzerland, a most commendable vaccination campaign was launched for children around the world. The chair of this initiative, Gro Harlem Brundtland, former Prime Minister of Norway, and then at the time the Secretary General of the World Health Organization, pointed out that 30 million children still don't have access to basic vaccinations. For only $17 per child, she said, we can provide lifetime protection against the 6 historical scourges: polio, diphtheria, tuberculosis, measles, and tetanus. And James Wolfenson, who was then the president of the World Bank and who was also present on this occasion, observed that health is a central issue in the fight against poverty. In China, it seems that the rollout of their COVID vaccination program was focused on 20-year-olds and 30-year-olds, the folks that would be out and about the most. Do you think that we've gone about this the wrong way?
Well, if you think about how we're set up and how China is set up, this is the one area where we have to think about what are the realities in life. We have a more open system where we don't have as effective control over our citizens. So at the end of the day, if you can regulate the distribution of citizenship, if you can physically control hotspots, then a program which has been very effective in China is realistic. If you can go out there and say, who are the spreaders, and you actually have the ability to use an adroit vaccine program, it makes sense to be able to do that. But when you're looking at the United States, where distribution varies from state regulation to state regulation, at the end of the day, it's a real problem in mandating even just mask wearing. So when you're talking about vaccination, to be able to ensure that the 20 and 30-year-olds are going to be vaccinated is a problem. So we went into a slightly different approach, looking at those people that would typically be considered to be the most vulnerable or in greatest need of vaccine. These are the older patients. These are the people that would, in theory, the first responders that would have more potential exposure to virus. Our strategy was not predicated on being able to stop it. Our strategy was predicated on being able to control who gets infected and to make sure that those the most at risk were given priority with the vaccination. So again, this is one where, given resourcing, given the realities on the ground, that two different decisions were arrived at, and candidly, probably the right decisions, although advocacy for the simple stuff, mask wearing and social distancing and limiting events, these are things that apply to both populations.
Do you want to take the question on how did mask wearing and vaccinations become a political statement?
Oh gosh, I guess everything is political today. I would say that information and this where you get information is a very, very interesting part of life today. A Russian researcher, I should say, a researcher of Russian origin up at Columbia Business School, wrote a paper about how viewership of different programming stations was actually possibly detrimental to your health. And specifically, in the early days of the virus, there was a preponderance of communicators on Fox that said that vaccines were not, that mask wearing was not essential. And as a result, you saw a distinct distribution pattern from those people who watched CNN, MSNBC, to those people who watched Fox, and their ability or their focus on wearing masks. And at the end of the day, these are, in some cases, subtle, but in some cases not so subtle reasons why we see a divergence within our country of mask wearing and the ability to go out there and explain why we have such a divergence in views of something as simple as that.
I think we have some very good questions coming up, and maybe I can dovetail with one of them, namely on the question of whether vaccinations should be voluntary or mandatory. Last week, we had the Lieutenant General who was Deputy Chief of Operations for the U.S. Space Force, and I was very surprised to hear him say that that it's voluntary in terms of whether members of that service have to sign up for COVID vaccinations. How do you feel about making the vaccination mandatory?
Well, having been in the service for 22 years, I don't remember a lot of options in terms of vaccination back then. But today we live in a different world. I would say that at the end of the day, we need to get as close to mandatory vaccination as possible, understanding that there still has to be limits around that no vaccine, no drug is without side effects. And at the end of the day, this is where we need to understand, and the dissemination of information has to be as efficient as possible. So in answering the question, I would say to you that we need to go out and make sure that there are no reasons, there are no illegitimate reasons to not get a vaccine. That people should not, there shouldn't be a way for people to go out there and, you know, literally cry fire in a crowded theater. And I think that that might take away a lot of the vaccine hesitancy that we're seeing. And actually, we're seeing something outside of the box. There's a question from Stephen Kalinsky. Vaccine hesitancy is a major problem. What might some US government steps be to address the issue? I think that it's part of not just vaccine hesitancy, but it's also part of the issues that we have around medicine in general, and the different levels of medical care that we get across the country. I think we need to, one of the positives I hope at the end of this will be a different approach to medicine. Let me see. Okay, we have one. What about 6 foot distancing versus 3 foot distancing? Very important for schools. I think that the point is a well placed one. Something as practical as the distance between 3 and 6 feet. I think that what counts more is the amount of circulation in a facility, and also to ensure that face covering is observed. You know, I'm sure everyone that's listening to this or watching this have seen a person walking around with one, maybe even 2 masks, but they're dangling below their nose and not even covering their mouth. Effective wearing of protective gear is probably just as important, and also some way around, you know, these particularly striking, you know, differences that we can measure. But it's something that we really do need to think about into how we respond to school openings.
As I recall, Steve, we were planning to do a book together on global health issues to come out as an FPA centennial publication to mark FPA's centennial in 2018. And the risk of infectious diseases was very much on our mind. What other global health risks would the book have addressed?
I think one that has become very, very apparent is the healthcare systems themselves, and specifically in the United States. I think it's critically important to understand how our healthcare system operates. What are the levers that we see innovation, that produce innovation, and what are some of the levers that might retard it, or in some cases effectively block it. I think that it's now time for a frank discussion, given the fact that we obviously are spending trillions of dollars today and trillions more into the future in combating this, that we have to now think about the entire approach that we've taken in healthcare, and understand what we're going to need to do into the future to make sure that we, first off, are able to deal with this pandemic. And then what do we do after that to deal with our healthcare or endemic healthcare problems, and by extension, what the world needs as well in healthcare changes. So that's probably the issue that is going to come off of that, and it should be addressed next as well.
And let me ask you about the US response when contrasted with that of other countries that were much more successful in addressing this terrible public health crisis. Do you think that, as Bill Hazeltine mentioned in his piece for the special edition of Great Decisions on this very question, that an absence of social solidarity has contributed to this crisis and to the huge loss of life that we have seen in the US?
I think it's a striking statement on how polarized we've become, of course. I think that if you look at social response to different therapies, if you look at social response to even just generally accepted principles, they've changed in the last 20 years dramatically. So I think it is in addressing the healthcare differentials. It's not just healthcare, but it's also how we do things in the United States. And one of the things that we also should consider is, and Michael Lewis wrote a book about how government is set up to react to challenges and issues, that, believe it or not, we really did have plans for exactly what has happened or what took place. It's just that between getting rid of the people that were in charge of implementing them, ignoring them, or even going out there and putting people that had other interests or motives involved, we did just about everything we could do to exacerbate the problem. So it's not that we didn't have something ready, it's that we deliberately chose to ignore it or make it difficult for the right or a good answer to be implemented. And that's something I think is one of the striking takeaways of what we're looking at today.
Steve, maybe we can take just a couple more questions. You're chairman and CEO of Storm Bio, a development stage biotechnology company focused on the attenuation of inflammation, namely the cytokine storm brought on by influenza. Can you tell us what progress Storm Bio has made?
Yeah, as a matter of fact, I think there are a couple of listeners on this that are on here today that were participants of Storm. Storm's approach was the realization that to go out there and to shut down a pathogen using an antiviral method was counterproductive, because at the end of the day, you were playing viral whack-a-mole with humans as the mole. So the idea behind it was to try and go out there and instead shut down the body's not just response, but over response to that pathogen. In H5N1, since it was such a novel flu virus, it came from birds, that it just devastated the lungs very, very quickly. And in that case, the problem solved itself because of two simple sugars on the virus that prevented the virus from being transmitted from the back to the front of the mouth. In this particular case, I'm sure there are going to be decades worth of research and Nobel Prizes awarded to understand how the coronavirus was made able to, with its spike signature, how was it made able to be as easy to transmit in humans as it is today. There is a significant difference in that we don't see the same cytokine, the classical cytokine storm that we saw in H5N1, H1N1, or even other pathogens. What we're seeing here is like I said earlier, a microvascular attack that causes a global coagulopathy throughout the body. And that's something that is different. Now, much later on, or in some cases not that much later on, you start to see the same exact damage that takes place because of other comorbidities or other problems. But the idea isn't to go out there and be able to treat a bug. It's to be able to work with the body to treat either an immune response, or in this case, an immune over response. And we're still focused on it, but it's just being able to find the right therapeutic that doesn't cause more damage than good, and understanding that, there is no silver bullet, as they used to say in anti-infectives. Antibiotics work, but you have to understand that, one pill does not fit all solutions. And the same applies, obviously, for therapeutics in dealing with COVID or, candidly, most other infections. There is one other question here. Let's see. Is it perhaps possible to elaborate a bit more on different types of vaccines currently out there? And why not on manufacturing one brand of vaccine to boost people's confidence? The reality is this, that the approach is whether, and it's a really good question. And I on the vaccine side, again, I'm a strong advocate for vaccines. The mRNA vaccines, which have become very, very popular, they are snippets of vaccine technology that were funded by the U.S. government for more than 20 years before they actually became commercially possible and available. These are vaccines that trigger a very rapid immune response and are done by using technology that it's not recent, but it's only been commercially used of late. That's as opposed to, let's say, the original adenovirus vaccines, the Janssen one, Johnson & Johnson, which is one that uses another virus vector or another virus vehicle to be able to transmit the antibodies into patients. The Achilles heel for all of these vaccine programs are the manufacturing. It isn't enough to go out there and you can't just manufacture enough of one of them. And the other parts are that if you had dedicated everything that you were doing to manufacturing or developing just one and then it failed, then you'd have nothing. So the realities are that we have multiple vaccines and we are limited in vaccine manufacturing prowess. So the idea is now not just to focus on vaccines and boosters into the future, but also focus on the necessary therapeutics and diagnostics that can lead us into greater confidence, because obviously that's one thing that I do want to impress. It's important to restore confidence in healthcare and specifically in this battle against COVID.
Steve, maybe we can take a last question from Leonard Levy, who asks whether the US government has failed to vigorously address a key cause of COVID-19 vulnerability, namely extremely poor diet and exercise habits by many Americans. A very integral part of the healthcare situation, I would think.
I think that it's when we see documents about patients affected and outcomes, the first thing that you look at are what were the comorbidities, and I can tell you without even thinking, the comorbidities that cause the most problems are type 2 diabetes, obesity, any kind of tobacco product usage, and any kind of issues around that poor diet. So all of these issues not just complicate COVID, outcomes, but also to some degree almost guarantee, problems. So I think, again, in going back to and ending on triage, we've got to deal with the realities of these patients as they are today. And then we've got to figure out what we're going to do to change that into the future. And I think that's the important takeaway from that question.
Steve, I want to thank you very much for sharing your extensive knowledge and expertise with us today. I hope you'll have some good news about medical breakthroughs when we reconvene in person.
I'm looking forward to that, and I'm looking forward to obviously that ability to not just say this is the data we need, but this is what the data we've got has produced. But thank you again. Thank you to the Foreign Policy Association, and thank you to Dame Sackler.